this is Brandon with ChiroUp. I want to talk to you today about classification. I think it's important to do. I think you should do that on every patient, every condition, every single visit. Most importantly, obviously, the exam and the re-exam. We have to understand how things happen. We have to understand the difference between the tendinopathy and the tendinitis. We have to also understand the different kinds of structural problems that can happen in the body and where that person falls within the continuum of shoulder pain or back pain, whether it's a disc problem versus a facet problem versus a DJD versus stenosis, because it matters. It matters in our rehabilitation and it matters in our patient education. I think McKenzie, the directional therapy, does an excellent job of this. They've done a great job as far as pouring out research to make their results valid. And there's no question that classifying patients and also treating patients with this specific method works very well. In fact, I use it on 95% of my patients that I see in my practice in some fashion. For those of you who aren't familiar with McKenzie directional therapy, it's classifying people into three different dysfunctions. You have your postural dysfunctions, you have your actual dysfunctions, and your derangements. The most common being the derangement. We all know that postural stuff is more functional things, the things that are the habits and the hobbies and the things that people put themselves into, and it creates problems. Derangement is that intermediary where there's a functional problem, but it's not necessarily seen on an image, whereas the dysfunctions are more the actual structural problems. There's tissue damage, there's adhesions, there's tight muscles, and derangement is the most common. And we as chiropractors know that a lot of patients fall into this specific category. However, what is it and why does it matter? And that's the purpose of this blog, is to dive into that just a little bit. I was under the assumption, and I'm still somewhat under the assumption, that it has to do with fluid dynamics of the disc. That when people go into extension, that neuroforamen does get smaller. That should compress down on the actual nerve, and it should make things worse if they have a disc problem. But the simple fact is that a lot of people with derangement syndromes or sciatica or radicular symptoms, they like this. It feels good to go into extension. So why does this happen? Why does this happen with such a high incidence? Why do we see so many people feel better with an extension problem or a back problem that go into extension? And I think the problem is solved with directional therapy, and their process is on fluid dynamics, and it's looking at when you go into extension, the disc actually moves forward, the nucleus moves forward, as long as you have obviously an intact disc and the annulus is well preserved. And McGill says if you have above 70% of disc height left, meaning you don't have too much degeneration in the area. And the process used to be that you do repetitive extensions to help take that disc and shove it back forward and to alleviate symptoms. And I still think there's a portion of that to be true. This new article in this blog says may not be just disc mechanics. It may be just taking the shortened material in the front of the disc and the improper disc mechanics and joint mechanics, saying that somebody is sitting more often, they're being too sedentary, or they're spending too much time in lumbar spine flexion or repetitive stress in lumbar spine flexion. They just need full range of motion. The number one predictor of low back pain is the ability to extend. It's the same thing you see in a knee pain. What do they lose? The ability to extend. So our patients have a repetitive stress or hobby that puts them into repetitive flexion. The tissues get kind of molded in that position, shorten on the front, lengthen on the back, and they get irritated on the back. Just getting them back into an extended position on a repetitive basis works really well. If you're doing extensions with your patients, don't push them past pain. Nerves don't like that. Make sure they touch the pain and come back out. Check out ChiroUp as far as the extension bias low back pain protocol. There's a flexion bias low back pain protocol. There's all the directional preference exercises in the exercise plans for the cervical region. It tells you how to prescribe these exercises, how to use those to get the best possible patient outcomes. And our goal is just to spread information. This new blog article doesn't necessarily, it's not groundbreaking, but it says, you know what, there may be more at play, and we as chiropractors know that. We absolutely know that by giving a joint full range of motion, by allowing somebody to move through a full range of motion, by reversing the activities and the postures they do on a regular basis, we get great results. And I think this is one of those papers that's good knowledge, but also we have to do what works. And the simple fact is directional therapy works. I highly recommend checking out their seminars. Thanks.